In today's video, we'll tackle two high-yield clinical questions to sharpen your reasoning skills. The first question focuses on identifying the cause of macrocytic anemia in a patient with chronic liver disease and alcohol use. And the second one explores the management of a delayed gastric emptying in a patient with long-standing diabetes. A 45-year-old woman is admitted to the hospital because of progressive fatigue, swelling in her legs, and abdominal discomfort. She has a long history of heavy alcohol use and reports poor appetite over the past few months. On examination, she has ascites and bilateral pitting edema. Laboratory tests show elevated prothrombin time and INR, low serum albumin, and mild thrombocytopenia. Her hemoglobin is 9.8 with a mean corpuscular volume of 112. Further testing reveals elevated homocysteine levels with normal methylmalonic acid levels. Which of the following is the most likely cause of her hematologic findings? Now, in this question, focus on the patient's history of alcoholism and the signs of liver disease, which point towards nutritional deficiencies. Also note the macrocytic anemia, which is represented by the high MCV, and also focus on the elevated homocysteine with the normal methylmalonic acid level. These key features help differentiate the underlying cause of the condition from other possible explanations. The options given here are A. Vitamin B6 deficiency, B. Folate deficiency, C. Selenium deficiency, D. Vitamin A deficiency, E. Vitamin B12 deficiency. The correct option here would be B. Folate deficiency, and that is because alcohol impairs folate absorption and folate storage in the liver, making deficiency common in alcoholics. Folate is required for DNA synthesis, so deficiency leads to impaired RBC production, resulting in macrocytic megaloblastic anemia. Now, homocysteine is metabolized to methionine via a folate-dependent pathway. So when folate is low, homocysteine levels rise, and methylmalonic acid remains normal. Now, this finding helps to distinguish folate deficiency from vitamin B12 deficiency. Let's have a look at why the other options are incorrect. Option A is incorrect because vitamin B6 deficiency can cause sideroblastic anemia and neuropathy, but it does not raise homocysteine levels. And option C is incorrect because selenium deficiency does not cause elevation of homocysteine, and it can result in hypothyroidism and heart failure. Option D is incorrect because vitamin A deficiency causes vision problems like night blindness, skin issues, and immune dysfunction. They have no effect on MCV or homocysteine levels. And option E is incorrect because vitamin B12 deficiency can cause macrocytic anemia and elevated homocysteine, but it also elevates the methylmalonic acid and often presents with neurologic symptoms like paresthesia or gait disturbances. A 42-year-old woman with a 15-year history of type 1 diabetes presents to the clinic complaining of early satiety, nausea, and occasional vomiting after meals. She describes a persistent feeling of fullness and mild upper abdominal discomfort. Physical examination reveals a soft, non-distended abdomen without tenderness or palpable masses. A barium swallow with small bowel follow-through demonstrates delayed gastric emptying. What is the most appropriate next step in management? The options given here are A. Bethanechol, B. Lansoprazole, C. Metoclopramide, D. Triple therapy with omeprazole, amoxicillin, and clarithromycin, and E. Ranitidine. The correct option here would be C. Metoclopramide, and that is because this patient probably has gastroparesis, a condition of delayed stomach emptying due to neuropathy commonly linked to diabetes. The first-line treatment is a gastric motility stimulant. Metoclopramide works by blocking D2 dopamine receptors and activating M1 muscarinic receptors, which together enhance gastrointestinal movement. Let's have a look at why the other options are incorrect. Option A is incorrect because bethanicol is a cholinergic drug that stimulates the intestinal smooth muscle contraction and will enhance the lower esophageal sphincter pressure, but it has no effect on gastric emptying time. And option B is incorrect because lansoprazole is a proton pump inhibitor which decreases the gastric pH but do not increase gastric motility. And option D is incorrect because this regimen treats H. pylori infection but does not improve gastric emptying. And option E is incorrect because ranitidine is an H2 blocker and it lowers gastric acid, but they do not enhance gastric motility.